Welcome to this comprehensive fellowship video on pulmonary air leaks in the neonate. We will cover the pathophysiology, diagnosis, imaging, and evidence-based management of these conditions. This topic presented by me, Dr. Salim Keshba, neonatal specialist. Our video is structured around 6 integrated sections, moving from the fundamentals of epidemiology and risk factors through pathophysiology and classification to clinical diagnosis, deep dives into specific conditions, and finally, prevention strategies. Pulmonary air leak incidence varies significantly. It's 1 to 2% in term infants with spontaneous leaks, about 6% in preterms on mechanical ventilation, and up to 40% in extremely premature infants with RDS requiring high-frequency ventilation. Patient risk factors include extreme prematurity, RDS, and congenital lung anomalies. Ventilation-related risks involve high peak pressures, large tidal volumes, and prolonged inspiratory times. The pathophysiology follows 4 steps: lung injury from overdistension, alveolar rupture, gas dissection along bronchovascular bundles toward the hilum, and finally, the clinical syndrome. The key insight is the Macklin effect, where air dissects centripetally, making pneumothorax often secondary to mediastinal air rupture. Air leaks are classified into 4 main types. Pneumothorax is the most common, where air is in the pleural space, with tension PTX being an emergency. Pulmonary interstitial emphysema is air trapped in the interstitial tissue, often a precursor to other leaks. Pneumomediastinum is usually self-limiting air in the mediastinal space. Pneumopericardium is the rarest and most dangerous, a life-threatening emergency. This cartoon illustrates the various forms of air leaks, showing the location of trapped air for pneumothorax, PIE, pneumomediastinum, and the combination of pneumothorax and pneumopericardium. Pneumothorax presents with sudden respiratory and cardiovascular deterioration. Tension PTX signs include muffled heart sounds and cardiovascular collapse. Transillumination offers a rapid bedside diagnosis. Chest X-ray findings include a visible pleural line, absence of lung markings, and medial stinal shift in tension cases. Here are visual examples. The top panel shows positive transillumination in a patient with left-sided pneumothorax. The bottom panel displays CXR findings, with air separating parietal and visceral pleura, and collapse of the left lung in a bilateral case. Pulmonary interstitial emphysema involves air trapped in the lung interstitium. It primarily affects extremely preterm infants on mechanical ventilation. Management focuses on minimizing ventilatory pressures, cautious use of PEEP, and options like HFOV, or selective intubation for unilateral cases. Neomediastinum, typically a benign condition in term infants, is air accumulation in the mediastinal space, often anteriorly. Diagnosis by CXR involves the Spinnaker-Sale sign. Management is usually conservative, focusing on supportive oxygen, pressure reduction, and spontaneous resolution within 24 to 48 hours. Pneumopericardium is a critical neonatal emergency, carrying a high risk of cardiac tamponade. Recognition of sudden hemodynamic collapse and a CXR halo sign mandates immediate pericardiocentesis without delay. Stabilization involves reducing ventilator pressures and volume boluses.
Lung ultrasound is a rapid, radiation-free tool for air leak diagnosis. Lung sliding is a normal finding that rules out pneumothorax at that site. Absence of sliding with A-lines suggests pneumothorax. The pathognomonic lung point sign confirms pneumothorax, while B-lines and comet tails suggest interstitial fluid or PIE.
This ultrasound image shows the transition point between the air-filled space and the lung parenchyma, which is characteristic of a lung point sign and confirms pneumothorax. The M mode shows the transition from the stratosphere sign to the lung sliding sign. Prevention strategies are critical. Antenatal care, including corticosteroids, reduces pneumothorax's incidence. Respiratory support should favor volume-targeted ventilation and strategies that avoid excessive peak inspiratory pressures. Surfactant therapy reduces overdistension risk. Monitoring includes continuous SpO2, PCO2, and lung ultrasound surveillance. In summary, Air leak incidence scales with prematurity, with the Macklin effect as the core mechanism. PIE often precedes other leaks. Pneumopericardium is an immediate emergency requiring urgent pericardiocentesis. LUS and transillumination are rapid diagnostic tools. Finally, volume-targeted ventilation and surfactant are key preventative measures.